Did your doctor seem puzzled about the cause of your dizziness lying down or the dizziness you feel when you sit up in bed or get out of bed? Did a healthcare provider say that your eyes are going the wrong way when they were testing you for BPPV? Or maybe tell you that you don't have BPPV because you didn't have any eye movement during your BPPV testing? These are all sneaky ways that posterior canal BPPV can be missed. They puzzle a lot of doctors. In this video, I will discuss 5 sneaky variants of posterior canal BPPV. I am Kim Bell. I'm a doctor of physical therapy and the Vertigo detective. And just a reminder that this is not individual medical advice. I provide this channel in order to offer information, education, and hope to people who are suffering with dizziness and vertigo. Be sure to stay to the end so I can show you another video that you might find helpful. Since this is a pretty technical topic today, I want to take a look now at a blog I wrote on this exact topic, 5 variants of posterior canal BPPV. We're going to go through each of these sneaky variants individually, and we're going to look at a diagram that I had my graphic designer create just so that I could teach this to you and explain what I'm talking about. You can thank my husband actually for this because he would rather watch a video any day of the week than read one of my blogs. And I realize there's a lot of people in the world just like my husband. So I'm choosing to present this information from one of my recent blogs in a video format today. If you like this idea, please comment and like this video. So now here we are looking at my website, betterbalanceinlife.com. This is actually one of the new blogs that I just published. I'll show you right here. If you scroll down on my home page, you can find my recent blogs. So I just published this on November 26th. So if you happen to see this video around the time that I'm making it, you'll find it right here on the home page of this website. But just in case you find this video years down the road, I'm going to show you how to follow along with me by looking this up. So what you do is you go over here to the magnifying glass, click on that, and just type in the word posterior canal. 2 words. Type in 2 words, posterior canal. Okay, we'll hit search, and then you can come up with this posterior canal BPPV variants blog that should be available once you search the phrase posterior canal. Then you can click on the blog, and here we are. This is the diagram I told you about that my graphic designer created so that I can explain to you how these variants work and why they puzzle so many doctors. So just a quick sidebar, remember BPPV is benign paroxysmal positional vertigo. This is the most common inner ear cause of dizziness and vertigo. And it's caused by crystals that are displaced within the semicircular canals of the inner ear. So let's take a look at this. This is an example of an ear in the vestibular system here, which is deep to the middle ear. So if you just look into someone's ear with a light, you can't see this. This is actually in the cheekbones here, deep inside the inner ear. So let's take a look at the anatomy. This organ right here called the utricle, let me see if I can make this any bigger for you. There we go. Okay, a little bit bigger so you can see it a little bit better. So this organ right here called the utricle is where the crystals belong. That's where they were when you were formed in your mother's womb. That's where they've been your whole life. They actually have a job there to sense when you speed up or slow down in a car or in a train or on an elevator or an escalator or a plane. So when you're moving forward, backward, side to side, up and down, or any combination of those movements, you're accelerating or you're decelerating or you're tilting your head. That's what this organ is designed to sense. And so the crystals belong here as part of that function. They are normally here, okay, attached. And so when they come loose, they can go in a variety of places. Most commonly, you're going to feel the vertigo initially when you're lying down in bed or getting up out of bed. And in that case, the crystals will have gotten loose right here in this utricle area, and they will have gone up this area where I'm drawing with my arrow here and down this tube while you were sleeping. This is the long arm of the posterior canal. And then when you got up in the morning, they went the rest of the way down here and they settled right in here. Okay, so this long arm of the posterior canal is what we call classic posterior canal BPPV right there. So that says classic posterior canal BPPV. It's canalithiasis, and those crystals are right here sitting in the long arm of the posterior canal. Let's take a look at the article now, and then we'll come back up to this diagram to tell you more. So classic posterior canal BPPV shows nystagmus. This is involuntary beating, ticking, fluttering of your eyes, however you want to describe it, but your eyes are bouncing around out of control. You have no control over them when you're in the testing position for BPPV. And classically, the patient will complain of spinning vertigo during BPPV testing and during certain activities of their day, like looking up, maybe bending over, lying down in their bed, sitting up in bed, getting out of bed, rolling over in bed. These are examples of positions that may cause the eyes to jump around involuntarily, eliciting that nystagmus, or trigger the spinning vertigo symptoms. So that's called classic posterior canal BPPV, where the crystals are displaced into the long arm of the posterior canal. And this type of BPPV typically resolves with the modified Epley maneuver or Simont maneuver. Those are the most common treatments we do for the classic posterior canal BPPV. You may already be familiar with that. Maybe we're starting from there with you learning now about the 5 variants. Let's take a look at what they are. Variant number 1 is going to be what's called type 2 BPPV. This puzzles a lot of clinicians because the patient usually feels dizzy in the testing position and they complain of dizziness throughout their day in the manner that I described, but they don't have any eye movement. So they have no nystagmus in the testing position. And classically, according to the textbook, you would never diagnose BPPV unless the patient has nystagmus, which is the eye movement. So therefore, this gets missed a lot of the time if clinicians are sticking by the textbook. One good thing is that they are now starting to do research about this type of BPPV. So this is called type 2 BPPV. And in my experience treating this for the last 18 years or so, I typically call it symptomatic BPPV. But in my experience, the crystals are usually in that long arm of the posterior canal. If they're in the posterior canal, they're in the long arm. And so we can see here, the treatments for type 2 BPPV are the same generally as classic BPPV, which is the modified Epley maneuver or the Simont maneuver. Okay, and again, because we don't see the eye movement, type 2 BPPV is actually proven in hindsight. So we only know for sure that you had it because then when we retest you for BPPV after treating it, it's gone. The symptoms are gone. And then you go through your day and you're not getting dizzy doing all those things I mentioned. Looking up, bending over, turning your head quickly. Oh, I didn't mention that, but now I am mentioning that. Lying down in bed, sitting up in bed, getting out of bed, rolling over in bed. So those symptoms from those motion activated situations would be resolved. And that's how we know in hindsight, yes, you had type 2 BPPV and now it's gone. Yay. And so if you want to check out a research article, an observational research article about type 2 BPPV that explains some of the theory of how this can even happen, then you can check this out here. I also have 2 blogs I've written about symptomatic BPPV here and here. So those are linked up in this article here on my website. The second variant of posterior canal BPPV is that the crystals can go in what's called the short arm. Okay, and this type of BPPV shows the classic nystagmus during testing, but Aha, here's the key. It does not clear up with the traditional treatments like the modified Epley or Seamont maneuvers. So this patient is going to have symptoms and nystagmus during the test, but when we do the typical treatment that works with long arm classic posterior canal BPPV, they don't get better. Okay. This type short arm posterior canal BPPV can also show what's called atypical nystagmus during BPPV testing. So it can actually show other types of eye movement that may confuse clinicians, where they may say your eyes are going the wrong way, or it's upside down and things like that. It depends on your inner ear anatomy, interestingly. Like if you look at two people side by side, their feet don't look exactly the same, although they function the same. Well, inner ears can be the same way. Sometimes people have slightly different angles in their inner ears than someone else. And that's the explanation of why some people with short arm canal BPPV may have slightly different types of eye movements. And advanced skills in BPPV treatment are necessary to identify this if the nystagmus is atypical or if the posterior canal will not clear. I actually wrote an article about this type of BPPV and the treatment, one of the treatments I use for it right here that you can find. But in order to explain this to you, I want to go back up to the diagram. So give me a second while I scroll. Okay, so here we are. So classic BPPV is down here, and that's when the crystals are loose in the long arm down in this position. And then type 2 BPPV is typically right here as well. It just doesn't show eye movement. But check this out. If the crystals slide off here, off the utricle, and they just go down like this, they end up in this section of the posterior canal. That is called the short arm, okay? So this is the short arm of the posterior canal. And this type of treatment will not necessarily clear with the Epley or Seamont, and that's what we use a different treatment for. But it does show symptoms and nystagmus in BPPV testing, but it won't cooperate with the doctor or clinician that's trying to treat it, and it may puzzle them. Why isn't this working? I know what I see. It looks like classic posterior canal BPPV. I'm doing the treatment correctly. Why isn't this clearing? Well, one possible reason is it's a short arm, and so we need a different treatment. Because this right here, this white thing in the diagram, is called the cupula, and this is actually the sensory apparatus within the canal. It is like a sail on a sailboat where it's tethered at the top and the bottom, and it spans the whole width of the canal. So therefore it's impassable, like a roadblock. Okay. So this right here, this cupula, you can't get past it. So if the crystals are over here, then the treatment needs to be to drive them back this way. Okay. That's a different treatment. Whereas if the crystals are over here, then the treatment like Epley's or Seamont's is going to be to drive them back this way. Okay, so they go the long way back to the utricle, whereas the short arm goes the short way back to the utricle. The goal of all BPPV treatments is to get the crystals back to home base, which is this utricle right here. Okay, that's the utricle. In this diagram, it looks like a little golden or orange egg or something right there. Okay, now the next BPPV variant has to do with this cupula, and that's why I told you about it. Crystals can get stuck on here. Think about like if you're sucking on a lollipop or a piece of gum, and you just you drop it on the floor and you forget about it, okay? Or maybe a kid does that. You forget about it. It sticks. So that's what we're talking about now. The next variant, the crystals can stick on this sail, this cupula that is sensing your motion from this canal. And so we don't know if the crystals are stuck on the long arm side or the short arm side, but let's take a look at how this looks when they're stuck. This variant is called posterior canal cupulolithiasis. So the crystals are no longer floating, they are stuck. So let's check this out. Classic BPPV is a condition of loose crystals displaced in the canals within the ear. Free-floating crystals is the most common type of BPPV called canalithiasis. if the crystals are stuck on the sensory apparatus within the posterior canal, that's the cupula, then the BPPV variant is called cupulolithiasis. Fancy words. It just means stuck crystals. In those cases, we will typically apply a vibrator or a vibration tool during an Epley maneuver. And we can also use a Semont maneuver with or without vibration to be effective to resolve the condition if the crystals are stuck on the cupula. Next variant, this is actually very interesting. I just saw a patient with this last week. This variant is called variant number 4 of posterior canal BPPV. Now, this is called vestibular agnosia. And this is a patient who's going to complain of chronic imbalance, disequilibrium, and maybe near falling, fear of falling, or falling. So falls and balance problems, but no complaints of spinning or dizziness in these cases that I've seen so far anyways. They have posterior canal BPPV in the long arm with classic nystagmus during testing. So I'm testing them for BPPV as part of my comprehensive exam, even though they're not complaining of spinning or dizziness, and they have nystagmus. They have their eyes are jumping in the test position in accordance with classic BPPV of the posterior canal, but they don't feel any vertigo or dizziness during the testing or treatment. So what do? We go ahead and treat them, okay? So I will go ahead and treat them with the modified Epley or Semont maneuver or whatever I think is appropriate for their case for the posterior canal classic BPPV. But interestingly, the patient won't feel any vertigo or dizziness during the testing, during the treatment at all. But yet, after the treatment's over, and I'm satisfied when I retest them that the eye movement is completely gone. It's resolved because I moved the crystals back into the utricle area during the treatment. The patient will stand up off the table and say, oh, wow, my balance feels so much better. My legs feel strong. I'm stable. I'm not scared to go walking. I can walk down hills now. I can walk down ramps, inclines, all those things that were previously treacherous for them. Now, here's something interesting about this condition. Who does this happen to? This typically occurs in young patients with brain injuries or older adults with unidentified brain issues or neurodegenerative disorders. Okay, so what we can conclude here is if the brain's not functioning normally, they may not feel the vertigo, but it can still cause them to have balance problems and falls. So that's vestibular agnosia. And the treatments for that are what we talked about for classic posterior canal in most cases, but the clinician or the doctor may not even test the patient for BPPV in those cases because they're not complaining of dizziness or spinning or vertigo. These are patients who just come in with the primary complaint of difficulty walking, imbalance, and falls, near falls, fear of falling, etc. Okay, now we're going to look at the final variant, and thanks for hanging with me in this video because there is a lot to cover here. But this should help you about why your doctor's puzzled by your BPPV. This is a more advanced topic, but I hope this is helpful to at least one person out there who's trying to recover from vertigo. Okay, so the 5th variant here of posterior canal BPPV is going to be called, all right, say this with me, guys, apogeotropic posterior canal BPPV, okay? So this is a really fancy way of saying that the eye movement is upside down and backwards. So it's an exact mirror image and inverse of what it typically would be expected to be. So here's the explanation for this, and then I'll go back up and show you the diagram as we wrap up this video. So within the long arm of the posterior canal, there are different segments. Picture a racetrack and then split it up into segments. So we have like the north side of the racetrack, the west side of the racetrack, the south segment of the racetrack, okay? And that's kind of what the posterior canal looks like when we think about this variant. Typically, loose crystals settle in the segment near the sensory apparatus. That's the cupula, within the long arm of the posterior canal. That's your classic BPPV. Thereby, the classic nystagmus pattern is produced. That means the eyes move in the way we expect during testing, as long as they have eye movement. Here's the catch, if the loose BPPV crystals in the posterior canal are heading towards the classic position, but they haven't arrived in that position yet, in that segment, then they're in a different segment of the posterior canal closer to the common crus. Interestingly, the nystagmus pattern shown during BPPV testing becomes inverted, like a mirror image, because they go the wrong way. And so that's why the clinicians may be puzzled when they're testing you, and they may say to you, your eyes are going the wrong way. Well, it's possible one of the explanations for that may be short arm of the canal, or you may have this apogeotropic variant. So another thing that they may think, this is a good example here, they may think that it's anterior canal also. So they may think you have anterior canal, they may think it could be short arm of the posterior, or it could be this apogeotropic posterior canal BPPV. Those all look fairly similar and can confuse beginner or intermediate level clinicians and puzzle your doctors, especially if they don't do this full time for like the focus of their whole clinic. It's really complicated stuff here. So this type of BPPV, the apogeotropic variant, can be successfully resolved with typical treatments like the modified Epley or the Semont maneuver. The only risk of this treatment would be that during the treatment, you can get what's called an Ipsy canal switch, which is when the crystals migrate from where they were down into the classic location, and then the eye movement will switch in the middle of the treatment and confuse the clinician. I talk more about BPPV complications in another video that I can link up in this description. But so that might confuse the clinician if they try to use an Epley or a Semont and then the crystals switch locations in the middle of the treatment, and therefore your eye movement switches. But the other treatment option for apogeotropic BPPV is right here. This is called a demi-Semont maneuver, which would just be the second half of the Semont maneuver instead of doing a full Semont. So I'm going to scroll back up now. And again, I want to show you now, here we are looking at this diagram. Just to recap, the crystals go in this utricle. Say it with me. Classic BPPV is in the long arm of the posterior canal, down here with the crystals loose, called canal lithiasis. Variant 1 was type 2 BPPV, which is when these crystals here don't produce any eye movement, but it can still resolve with treatment. The next variant is when the crystals come down here in the short arm. So this requires a different treatment because they need to go the short way home to the utricle. The next variant we talked about is when the crystals are stuck on this cupula. And therefore, that's called cupulolithiasis. For that one, we typically use vibration and more aggressive type treatments to break the crystals off of the cupula and then move them back to the utricle. The next variant we're looking at, this is our fifth and final variant, is this one right here, you guys. So apogeotropic posterior canal BPPV. This is when the crystals are right here. So they haven't yet gone all the way down to the classic position. They're up here. And therefore, a demi-Semont maneuver may be sufficient to move them back to home base. But if the clinician opts to try an Epley or a Semont, the traditional treatments for posterior canal, then the crystals can switch from this position, which is near this common crus. This is an anatomical feature of the inner ear, the common crus. It's like a intersection, like a fork in the road. If the crystals switch during the treatment, they'll go from here down into the classic position during the treatment, and then your eyes will switch directions in the middle of treatment. And then the clinician has to bring them all the way back up and back to home base. Okay, so that was a lot of information, but I hope that was helpful. This is kind of a more advanced video for patients who are kind of in the throes of dealing with posterior canal BPPV and maybe not getting the results they were hoping from the Epley maneuver. So I have another video here about why else the Epley maneuver may not work. I have 5 specific reasons I talk about why the Epley may not work. That's more content in addition to what I shared in this blog about variance. So go ahead and check out this video here and let me know if this was helpful. Please drop your thoughts in the comments. I love hearing from you.